So, welcome to the 56th edition of the MENASO Education Academy Cerebrovascular Grand Round webinar in collaboration with the Society of Vascular and Interventional Neurology, SVIN, which is titled From Large Core to Distal Vessel, Innovations in Stroke Diagnosis and Intervention. We connected with more than 9,000 participants worldwide last year, creating a dynamic platform for shared learning. This year, we are thrilled to collaborate with prominent international societies to bring your session featuring the latest research and engaging discussion, all dedicated to driving progress in cerebrovascular care. I would like to welcome my co-moderator from the session, Dr. Ahmed Nasruddin. Please, Dr. Ahmed, go ahead.
Thanks, Dr. Ghanem, for your kind introduction. Today, we will explore the complexities of cerebrovascular medicine with two exciting talks: the exceptional and outstanding Dr. Tan for large core stroke, and I think this is particularly relevant topic for low resources settings and where there is maybe a lack of experience in radiologists to interpret the studies. Dr. Nguyen's insights will help us to know how to optimize stroke care when resources are limited. Following that, Dr. Anas Al-Rahimi will discuss medium and distal vessel occlusion. We will also have two insightful case presentations by Dr. Mahmoud Naguib and Dr. Firas Akbik. These are highly relevant and timely topics, and I'm confident you will find the session both informative and engaging. Please note that the question and answer session will take place after the final lecture. And now it's my pleasure to introduce our first speaker, Dr. Mahmoud Naguib, who will present the mechanical thrombectomy for medium vessel occlusion in the late time window. Dr. Naguib is a neurologist specialized in vascular and interventional neurology. He serves as a lecturer and a consultant at Asyut University Hospital in Asyut in south of Egypt, and he is also worked as a consultant at many specialized hospitals in southern Egypt. He holds an at Asyut University.
It's a great pleasure to be in this webinar. Thank you, Dr. Ahmed, Dr. Muhammad, my big brother, Dr. Ahmed Nasr, who support me always, all the time, and always give me a big support in my back. Thank you, Dr. Adel Hazani, for this great time to be a part of this webinar. We will talk about two case presentation. Medium vessel occlusion underwent mechanical thrombectomy. I will share the presentation. The first case presentation was male patient, 57 years old, presented to the emergency unit with progressive left-sided weakness, left hemifacial weakness, and dysarthria. The time of presentation was about 6 hours and 40 minutes. Initial NIH stroke scale was 12. CT scan show no signs of hematoma, no signs of large vessel occlusion. This patient underwent mechanical thrombectomy. Mostly he was military personnel. He was highly recommended. This one was done with my professor Ahmed Al-Basyouni. Risk factor for this patient was hypertensive with admission blood pressure 170 over 100. Patient was cardiac ischemic heart disease on antiplatelets. This is the first DSA of the patient. Superior division of the middle cerebral artery appeared to be completely occluded with inferior division. Superior division gives a high parietal part from the parietal lobe that represent a more eloquent area than the inferior division. This patient, after the first DSA picture, me and my professor, Dr. Ahmed Basyouni, want to give him a chance for recanalization. As this arrow shows the site of superior division occlusion. Using a soft guiding catheter introduced to the base of the skull, internal carotid artery, with a Markesman microcatheter and microwire 014 was introduced, Texas microwire, with a good decanalization from the first pass with a stent retrieval, and this patient showed good recanalization with TICI score 3. From the first pass, this patient follow-up showed marked improvement in the NIH Wood 3, improved from 12 to 3 NIH score. 3 months MRS follow-up was 1. This patient, according to the guidelines, he would underwent only a medical treatment, best medical treatment, dual antiplatelet and statin, that would not be enough to improve this kind of degrees in the NIH. This is the first case. The second case, we just doing this case at 4 a.m. just yesterday in Malawi Specialized Hospital. It was a female patient, 37 years old, presented to the emergency unit with headache, with mild hemifacial weakness. This patient was misdiagnosed in the first presentation by her physician, as she had no risk factor, no vascular risk factor. So with the initial CT show no any signs of large vessel occlusion or any hematoma. So her initial physician suggests that it's a temporary headache not related to a cerebrovascular stroke. Then the patient developed progressive left-sided weakness, marked left hemifacial weakness, and dysarthria with NIH plus minus 13. As I said, that the patient had no any vascular risk factor that suggested by her physician that this condition must probably is not related to cerebrovascular stroke. And this is the reason why this patient missed the time for RTBA. The patient then was about 8 hours after the presentation. As I said, the initial CT scan showed no hematomas with no sign of large vessel occlusion. When the resident neurology called me, I said to him to try to rapidly do MRA, and we can find a diffusion flare mismatch involving the insular region and a part of parietal region that showed diffusion restriction with or faint finding in the flare. The initial MRA was suggestive of a middle division, and this patient was trifurcating M1, trifurcating into 3 branches. This picture is can you see this picture? Is that clear? The initial MRA shows that the superior division not completely filling, and the middle and inferior division were absent in the MRA. So this case had a miracle. I just traveled 2 hours to reach this patient. I was far away from here, and thanks God, we reached in the time. The initial blood pressure was 150/100 with normal random blood sugar. This is the initial DSA that may show firstly as M1 or a large vessel, not a medium-sized vessel. When we rotate the tower of the angio suite, we can see the bifurcation and superior division filling slowly, inferior division faint flow. This after the recanalization, we had another video of good recanalization showing TICI score 2B. Part of inferior division not recanalized enough, but we could not proceed further as the patient was 8 hours, and this is about 2 hours late after the 6 hours. It's a golden hour for mechanical thrombectomy, and as we know that M2 is still controversial in the mechanical thrombectomy. This is the thrombus that we retrieved by a stent retrieval solitaire EB for 40 30 and over a synchro microwire. According to these guidelines, those patients for medical treatment as non-dominant or medium-sized after time window for RTBA. And I think if we use the dual antiplatelets only for both those patients, we would show no improvement like the mechanical thrombectomy had shown. I will show another case. This case was M1 occlusion developed secondary MEVO. Secondary MEVO involving the inferior division. Superior division was feeling good enough, and the inferior division was not feeling good enough. But also in this case, it was done about 7 hours after the onset. We does not have we does not try to have a much more trials to avoid reperfusion injury. This inferior division was reflecting ischemic core in the temporal loop, and I saw this patient after 1 month with NIH0 with no deficit, with market improvement. This was 40 years old patient and with no risk factor as a previous patient. Distal trial that was going in the past has been shown that the best medical treatment and mechanical thrombectomy were fair enough equal to each other, and mechanical thrombectomy not adding any benefit, not improving the outcome in relation to the best medical treatment, and this were published in England Journal. But we had a study of mechanical thrombectomy of medium-sized vessel occlusion in collaboration with Shams University. Unfortunately, this study was stopped due to lack or scarcity of resources. There was a national financial problem in the supplementary and the resources, the small-sized solitaire, the microwire, not always available in our country. So we stopped this study after 2 years. We could classify the patient into early time window and early late. Early late, that was more than 6 hours, but not exceeding 8 hours. And both show good improvement with no definite difference between mortality and morbidity. I think we need further randomized controls trials about the medium-sized and the medium distal vessel occlusion, giving the possibility and may we save more patients, especially patient with superior division, as the superior division is more precious than the inferior division, giving high parietal cortical region that may leave a residual deficit. Thank you for attention.
Ahmed, for your kind and nice presentation. Do you hear me?
No, yes. Are we going to take questions now, or do you want to leave them to the end?
Yes, at the end.
At the end, okay. So for some emergency cases, Dr. Firas Akbek, he's stuck in a case, so we'll just give him a chance to present. And thankfully, and thanks to Dr. Tanwin to jump in and give her talk. It is very weird for me to present someone that I respect so much, and she is the president of the society that I'm a part of it, and I'm very proud to be part of it. I would like to introduce the president of the Society of Vascular Intervention and Neurology, Dr. Tan Nguyen, who will present, "Do we still need advanced images for large core stroke?" So it's, if I'm going to start introducing my friend and colleague, Tan, I will not finish, but I have to give her some introduction. So she's the Director of Intervention Neurology, Neuroradiology at Boston Medical Center, and Professor of Neurology, Neurosurgery, and Radiology at Boston BUSM. She's the President, as I said, of the SVIN Society. She's Principal Investigator of the CLEAR, which is CT for late endovascular reperfusion study, and the primary result published in JAMA in 2022 and Neurology in 2024. She's the co-PI of Picasso Summit Max trial, and she serves on the steering committee and as a co-author on multiple acute stroke clinical trials, hemorrhagic stroke, including trials related to endovascular therapy, neuroprotective therapy, adjuvant pharmacotherapy, and novel devices. She has authored more than 600 peer-reviewed publications, including acute stroke clinical trials in New England Journal of Medicine, Lancet, and JAMA. She has also contributed to national guidelines and international also work as well. She serves as an associate editor of stroke and on the editorial board of the SVIN journal. Without further ado, please, Dr. Tan.
Mohammed, thank you for the too kind introduction, and thank you so much to the organizing committee, Dr. Ahmed Nazir al-Din, for having me. And it was great to hear Dr. Naguib giving a wonderful talk. My assignment today is to speak about, do we still need advanced imaging for large core stroke? And so I will focus mostly on large core today based on the assigned topic. These are my disclosures, some of you've listened to in the introduction. So large ischemic core comprises about approximately 1 in 5 patients who have a large vessel occlusion. This was a nice study done by Max Moken when he was at Buffalo, when he looked at how often do you see patients with large ischemic core in your practice, if those who have LVO. And this was approximately 16% in the early window, so not very common, but it becomes more common in the later window as the stroke matures. So it becomes 1 in 4 to 1 in 5 patients have large vessel occlusion and large ischemic stroke in the later time window. So that's what you expect in your practice. About 1 in 5 patients to 1 in 4 patients will have a large ischemic core. And as you see from the Hermes meta-analyses, when they looked at the patients with large ischemic core, they found a signal of benefit when you had endovascular therapy compared to control. And so because the numbers were so small, only about 110 patients in the subgroup, this was the launch of many other trials, the 6 randomized trials that just came out in the last 2 to 3 years, looking at the evidence to support endovascular therapy for patients with large ischemic core. And these trials were conducted across many countries, several continents, almost every continent being covered. And this is just a summary to show you what these patients comprised of, who were the eligible patients, mostly adults with high NIH stroke scale scores, with large vessel occlusion, anterior circulation, and everybody had in aspects of 3 to 5. The imaging modality did vary between trials. So you have Rescue Japan Limit, which was MRI-based. You have Angel Aspects, which was perfusion-based. Select 2, perfusion-based. Tesla, CT-based. Tension, also mostly CT-based. And then last, which was MRI-based. And this is relevant because it'll frame how we think about selecting patients in the large core era. And so the question is, how do you define large core? You can do it 2 ways. One is by the aspect score, which you're very familiar with, the Alberta Stroke Program Early CT score. It's a quantitative or semi-quantitative score looking at categorical areas across the middle cerebral artery territory. You have 6 areas across the MCA cortex, and then the insula, and then 3 areas in the subcortex. So you score them for early ischemic changes. And if you're using it on CT scan, you will often have less penalty than if you had MRI, because MRI is so sensitive that you will detect more large ischemic core patients in the MRI or more early ischemic changes on MRI than on CT. The other way to detect large ischemic core is obviously on advanced imaging with perfusion, and the definitions that are traditionally thought of as large is more than 70 cc's is well accepted. 50 cc's was used in Select 2, and that was subject to a lot of criticism. So if you look at the trial, the patients who were enrolled were actually mostly 80 cc's or higher. So they still had large ischemic core, despite some criticism attacking that Select 2 included patients with small core, which would be 50 to 69. So it is controversial. What do you do about the 50 to 69 cc ischemic core region? So you can detect this ischemic core. Now you can detect it on CT, actually. There are programs that can do that, but traditionally it's by CTP or MRI if you measure the diffusion-weighted imaging area. And so as a summary, as you all know, the large ischemic core trials were positive in showing benefit of thrombectomy compared to medical care, with an odds ratio of approximately 1.6 times odds of better outcome with thrombectomy compared to medical care for the 9-day ordinal MRS. And this was our summary from a study level meta-analysis. The individual meta-analysis has not been done yet. And if you think about it in different ways in terms of dichotomized outcomes with functional independence, you can see that you still have better outcomes with thrombectomy compared to standard medical management. 1 in 5 patients will be independent compared to 1 in 10 with medical care. But you can see that most patients will not be independent because, again, they're coming with a higher severity of disease and illness. So 80% of your time, the patients will not be independent. And so you want to manage these expectations when you talk to families. And so this is how I stratify patients when I talk to them. I said, you can still benefit, but the benefit will not be as great. And then also, if you look at the endpoint of independent ambulation, which is a very clinically meaningful endpoint, you have very good results. 1 in 3 will be independently ambulatory versus 1 in 5 who are medically treated. So there's still a treatment modification, but the prognosis is not as beautiful as if you had a small ischemic core. The question that arises from these patients who have large core is that, well, what is the risk of symptomatic hemorrhage? And so it was astonishingly low that I thought, like only 5.5% when you collected across the randomized trials. And when we looked at in real life observational data, the symptomatic hemorrhage risk is actually higher. It's about 10%. So when I quote to patients, what is the risk of symptomatic hemorrhage, I go higher to 10% because this is in real life and I want to manage their expectations. The question is, does the size of the infarct matter when you think about who you treat? And so when we looked at this as a meta-analysis using the perfusion data that was present, it didn't seem to matter if the volume was high, more than 70 cc's, more than 100 cc's, or 150 cc's. They still seem to all benefit from thrombectomy compared to standard medical care. And then if you look at a different way with aspects 0 to 2 subgroup, and this could be adjudicated either by CT scan or by perfusion or MRI, then you see, again, across the 6 trials, it was positive, but this was largely driven by the last trial. The last trial, again, was MRI-based, and so they had the most contributors to patients in this 0 to 2 subgroup, 160 patients easily. But when we removed last from this subgroup analysis of aspect 0 to 2, we no longer saw this benefit, indicating that last was really driving the benefit for 0 to 2 subgroup when you just lump everything together. And then these are, patients post-hoc by imaging core lab adjudication where they saw, patients actually had aspect 0 to 2 instead of maybe 3 to 5 by entry. We move on to think about, well, does time to treatment matter? Because obviously time is a big metric that we think about when we offer endovascular therapy to patients. And so in Select 2, which again used perfusion imaging, didn't seem to matter whether patients were treated in the early or late window, they benefited. Whereas in Angel Aspect, which also used perfusion, at the 13-hour time mark, that's when they saw a fallout in terms of benefit of endovascular therapy compared to medical care. So there may be a component. And then if you look at the Tesla trial, which was CT-based, many will criticize Tesla. Well, it was a neutral trial, so CT doesn't work for this population, but it's not true. If you look at the 0 to 6 hour window, you'll see that there's huge treatment effect in the 0 to 6 hour window for Tesla, 20% absolute difference in better outcomes with thrombectomy. But in the late window, the margin is not as large. It's about a 5% increased benefit, but again, not significant. So the thought is that Tesla might have been underpowered as a 300-patient study to show benefit for thrombectomy. But in the 1-year data, you do see positive effect of Tesla that was presented at the International Stroke Conference, yet to be published. So Tesla, probably an underpowered trial using non-con CT, neutral in the early window, but so close to significance, and then turned out to be positive at the 1-year data mark. A very interesting question that arises is that, does penumbra core mismatch matter? And so this is obviously the basis by which we select patients, those who have salvable penumbra to salvage. And so there's several definitions, mainly 2 definitions that have really come across over the last few years in terms of how do you define mismatch. And so you can look at the first definition, which was used in Swift Prime, which was a mismatch ratio of 1.8, mismatch volume of 15 cc. So together these comprise mismatch. And so if you have that, it's considered a patient who's a go for treatment. If you don't, then you might say, okay, they don't have mismatch. Another definition that was used in Extend is more liberal, 1.2 for the ratio, and then 10 cc's difference between the core and the penumbra for mismatch. And so they looked at this in the 2 studies that actually had the perfusion to look at. And when they coalesced these 2 data, they looked at those who had no mismatch on the perfusion data, and they still were able to show, here you see in the bottom panel, no mismatch, that there was still a benefit for thrombectomy compared to medical care, almost suggesting that it may not matter if you have mismatch or no mismatch, as we traditionally thought, patients still benefit from thrombectomy, albeit these numbers are not great, are not high, it's only 160 patients, but it's still a signal to say that the mismatch part that we've been traditionally thinking about may not matter as much, especially if patients don't have a profound early ischemic change. And of course, that can be criticized because Aspects has a huge range of grays. You can see very dark gray, as you see here on the left-hand side. This CAT scan shows very severe hypodensity. This one on the second one, not as much, and then barely any ischemic changes as you move to the right. So there are many shades of gray of hypodensity, and so this was further investigated in the SELECT-2 trial, where they took a manual demarcation of the area of hypodensity, as you see here on the CAT scan, and they compared it to the contralateral thalamus, which is probably like the gold standard, and then they took what's the 5% confidence interval, and they defined this threshold of severe hypodensity as 26 Hounsfield units. And what they found was at also the 26 cc margin, where you have 26 cc's or greater volume of low Hounsfield units, your chances of benefiting from endovascular therapy are less good than if you were treated with medical management. So no significant benefit in patients who have higher volumes of severe hypodensity, as characterized by Hounsfield units on CT, compared to less severe hypodensity. And then substantial volumes of severe hypodensity are associated with more cerebral edema and higher need for hemicraniectomy. So you could use your CAT scan to help make that determination as how hypodense is the lesion to decide if they're going to go for thrombectomy or not. And so here again is just an example of the hypodensity of CAT scans. They haven't really issued a library of what these Hounsfield units look like, but if it's really obviously dark, then you can almost make an assumption that these are severely hypodense, established infarct, and may not benefit from thrombectomy, maybe just do medical care. And then the Tesla also looked at this, and also combining not only the hypodensity volume, but also looked at net water uptake. And what they found was that in patients with non-con CT Aspects 2 to 5, both the volume of the ischemic core and the degree of hypoattenuation, meaning how hypodense it is on the CAT scan, did modify the effect of thrombectomy on functional outcomes. In summary, again, that just supports you can use the CT scan as a way to triage patients and who would benefit or not benefit from thrombectomy. And one of the things that we were very curious about when we saw these patients with large core, well, what happens if you don't open the artery? Because that can happen in about 10 to 20% of patients. And so in Angel Aspect, which was the largest randomized trial for this large core population, we looked at unsuccessful vessel recanalization, meaning TICI 0 to 2A, and our primary endpoint was very poor outcome, meaning MRS 5 to 6, and there was essentially no difference between the 2 groups in terms of very poor outcome, because we don't expect them to do well. So even if you don't open the artery, similar rates of very poor outcome. However, you do have more infarct volume growth if you don't open the artery by endovascular means compared to medical care. And you do see more craniectomy in these patients. So it's just a word of caution of what to expect if you don't open the artery in patients with LVO and large ischemic core. So to sum it up, it would seem that this large core era is really lowering your boundaries or lowering your threshold to treating patients with thrombectomy. And what I highlight is, especially in your region, middle income, some areas low income. This was a very nice study led by Dr. Ahmed Nasraldeen and colleagues, where he looked at the availability of imaging modalities across low income, low LMIC, and then upper middle income and then high income. And what you see is hugely, 97% availability for non-con CT, very available. CTA, not too bad, pretty good availability throughout. But perfusion really drops out. If you look at it, the lesser the income, there's lesser availability of perfusion imaging, and also MRI, lesser available in these lower income countries. So you really have to think about, do you need all these advanced imaging, especially if you're in a resource poor area? You may not need it as much, and as you know from our work in the prior with the CLEAR study and then now with the large core, it really gives you a lot of ammunition to use your basic imaging to make decisions. And so this is an example of a patient with large core. The stars outline the areas of early ischemic change that we saw on CAT scan. And so this patient had an IC occlusion, and we scooped it out after 2 passes and saw this, moderate to large size ischemic core on imaging follow-up. And what was surprising was this patient actually was, anti-gravity with arm and leg the day after or the second day after his procedure. And I was shocked to say, why is that with this moderate sized core? And the answer is because that this motor cortex was spared. And so that's why even with in the setting of a large ischemic core, you can still benefit because the leptomeningeal collaterals may just help you get over the edge until you reperfuse the artery to get the patient to an ambulatory status. So the SVIN guidelines have issued, just a general thinking about how do you approach these patients with large ischemic core. And this is a little bit bold, but it does help change the way you think about patients. So they're saying in patients who have LVO 0 to 6 hours, aspects 0 to 5 on either non-con CT or MRI, EVT is recommended. And there was a lot of controversy when we discussed this as a group because some of us would say, look, you don't have enough evidence for aspect 0 to 2 because it's all on MRI based on last. But the counter argument was, well, there's so few patients like that it almost doesn't matter, that the imaging almost doesn't matter. If you tell me, you have a transfer patient, LVO, big deficit within the 6-hour window, right now, I almost don't look at the imaging anymore. I just say, accept the patient, transfer, just because I don't want to lose time on looking at imaging. I say that, well, that's a candidate right there. So it did change how I think about things in the 6-hour window. Just, the imaging almost doesn't matter as long as someone doesn't see a hemorrhage. And then if it's a later time window, then what these SVIN guidelines say is 6 to 24 hours, aspects 3 to 5, CT or MRI, EVT is a go, and that's fair based on the Angel aspect and the SELECT-2 data, which went to 24 hours, and also in part from Tesla, which is 24 hours, because the aspects could be 3 to 5, and it doesn't matter how much the core was. So you don't need to know how much the volume was, because they did not restrict based on ischemic core volume in either SELECT-2 or the Angel aspect trial. So that's why 3 to 5, we're pretty liberal, and we feel comfortable about saying, well, 3 to 5, NIH 6 to 24 with these additional caveats, it's supported by these data. And then what's uncertain in terms of, what about extended window aspect 0 to, there we hesitate and say we don't have data here because there is just not enough data. It has not been studied. And so we acknowledge that there's some uncertainty in this pool of patients where we don't know what to do with them in terms of treat or medically observe. And so these are the large ischemic core gaps, or the 0 to 2 with CT selection, and especially in the late window, and also in the early window, because there are so few patients that were represented in the trials in this category. The degree of hypodensity is still a hot topic. The role of mismatch in small and large ischemic core stroke is another hot topic. that deserve some investigation. And then what about adjunctive therapy? So the MARVEL trial, which was led by the Chinese, looked at methylprednisolone, and it had a really interesting signal in these large core patients, which, sorry, I didn't put on slides, but like, what do you do with these patients where they have so much more to gain with potential neuroprotection? So in conclusion, large ischemic core does predict a lower likelihood of doing well with thrombectomy, but does not modify its treatment effect. Earlier treatment is associated with more likelihood of benefit than later treatment, so you still want to go fast because these patients are considered to be fast progressors. Aspects 0 to 2 by non-Constantine, not sure. Even if there is no perfusion mismatch, based on the limited data we're seeing, there is a EVT benefit, but that's assuming there's no major hypodensity on the CAT scan. So you do have to look at the CAT scan. And then the greater the volume of severity of hypodensity on CAT scan, the lower the likelihood of benefit from thrombectomy compared to medical care. And so this basically supports that your simple imaging protocol, basic CT, CTA, is feasible for thrombectomy selection in light of this large core data. And with that, I, so happy to be amongst you in the MENASO organization. I've heard so many good things and really impressed by your turnout, and hope that you may have an opportunity to join us this November in Orlando. And with that, I cede.
Thank you very much. Thanks. Very, very interesting talk. Thanks. Go ahead, Dr. Ahmed.
Thank you, Dr. Naga, for your interesting presentation. Awesome as usual.
Thank you.
Or if you allow me, I think Firas is available to present his case. Let me just double check 1 second.
Yep.
Okay, great. So again, a friend of mine, a colleague, Dr. Firas Akbek, would like to welcome him to the speaker, who will be talking about advanced imaging in emergent thrombectomy decision. Dr. Akbek is a Syrian-American neurologist with subspecialty training in both neurocritical care and neurointervention radiology. He maintains a hybrid practice involving both discipline with an emphasis on advanced therapeutic for cerebrovascular disease. Please, Dr. Firas, the floor is yours.
Well, thank you guys very much for having me, and it's a pleasure to get to be a part of this event and this organization. So I just want to share with you two kind of interesting case experiences with emergent thrombectomy, highlighting the role for advanced imaging. One where advanced imaging was really quite helpful and made a meaningful impact, and one where advanced imaging, I think, probably would have helped us have a better outcome, quite frankly. So the first case is a 77-year-old woman. She has a history of a liver transplant. She came into the hospital in the setting of acute onset aphasia and hemiparesis on the right side. She had an NIH stroke scale of 13. She was mute. She had right arm paralysis, and then less so weakness in the leg and the face, again, all on the right side. So when she went to an outside emergency department, not our facility, and she got a CT/CTA on arrival, as you might expect. And I'm just going to show you the CT here on the right, and I'll scroll through it with you. But the preliminary impression from the CTA was that the left M2 had a little bit of stenosis, but the flow was open, and there was no role to call the neurointerventional service for this patient. And so just walking through, if you just keep your attention on the left MCA, there's a trifurcation that comes out, and it gets really busy around that trifurcation. And it's actually quite difficult to find an occlusion here. And if you scroll back down, with the benefit of hindsight, I've done this many times since, and it's really quite challenging to convince yourself that there is an occlusion. But nevertheless, this patient did in fact have acute onset left MCA syndrome. And fortunately, as part of their protocol, they got a CTP. And the CTP was quite instructive. And so, she did have a perfusion deficit without a CBF correlate in the expected territory that you would explain aphasia, hand weakness greater than arm, and arm weakness greater than face and leg weakness. It actually fits quite a nice pattern. So based on this, we brought her over and put her on the table and did an angiogram. Even on the AP, when you look at it, it's hard to tell where this clot is. It's obvious on the lateral. You see this big perfusion deficit in the superior division, or in one of the superior divisions, a better way of saying it. And you see a nice little truncation right here. So yes, on lateral, it's certainly easy, but on AP, it's not straightforward at all. And so you can imagine why it was difficult on axial imaging. We obliqued the AP to get a better view for our procedure, again, redemonstrating the clot in lateral. Did, I think, a 2-pass thrombectomy on her. We got TICI-2B 67 reperfusion. She still had some residual language difficulties, but her arm, face, and leg were all back to baseline afterward. Not baseline, but 4 out of 5 in the arm, and face and leg were pretty much fine afterwards. And so this is an example where CTP really does bail you out when it's very difficult to find M2, maybe an M3 occlusion on axial imaging, and CTP can at least show you a perfusion deficit that could correlate with your clinical concern for an acute ischemic event. The second case is a little bit more of a doozy. So this is a 52-year-old woman. She had a history of schizophrenia, pretty severe. She had very bad peripheral arterial disease to the point where she had claudication and had difficulty walking from the claudication. Coronary disease, didn't follow up with physicians very often, etc. She came into the hospital with some left-sided weakness. She was still anti-gravity, inattention, and confusion. She's brought in by her young children. The kids said that she was having progressive left-sided weakness over 2 days, give or take, but it's kind of a difficult to pin down story. She had an initial CTA on arrival, and that CTA was immediately notable for a right ICA occlusion down by the bulb. And then later, when the attending overread the CTA, it turns out that there's a mid to top of the basilar, it's actually mid to distal basilar occlusion that was not noticed on the first review of that CTA. So then the patient was re-examined, and now upon re-examination, the patient had flaccid paralysis on the left side. So just to show you, I'm going to walk you through this twice. Let's just pay attention to the ICA on the right side the first time, and then we'll review the CTA for the basilar next. So if you follow just the CTA for the ICA, you'll see here that there's hypoattenuation all throughout the course of the expected course rather of the ICA, suggesting that there is some clot burden here. How acute, how chronic, not that straightforward to tell, unfortunately. But certainly all the way up, there's a bunch of stuff in there, and then it reconstitutes at the level of PCOM, and then she's intracranially open on the right side. And then if we go back and now pay it with attention to the posterior circulation, now we're looking at the basilar artery as it starts to form, and kind of mid to distal basilar just drops out, essentially. So now we're in a little bit of a pickle because it's not totally clear what's acute, what's chronic, and what's relevant, essentially. So the exam was, ideally helpful to kind of navigate what's going on. That said, on exam, she's wide awake, her eyes are open, she's answering questions, she's confused and attentive, but she is answering questions. Her cranial nerve exam is a little bit of a doozy. She is blind at baseline. The right eye is enucleated. The left eye, pupils were fine, and it moved in all directions. It's hard to tell beyond that, essentially, given the limitations. She had a gaze preference to the right, and she had a facial droop on the left. She had left hemiplegia, and she had some sensory loss on the left side, and she didn't have any ataxia. So at this point, it's a little bit of a challenge because the question is, what are we doing? What are we going after? On the one hand, we could say she had an embolic shower. She has an exam that is consistent with the right MCA syndrome. She has a non-con head CT, which I haven't shown you, but she has multifocal remote embolic appearing strokes. She has a CTA with a clot burden visible in the right ICA. So you could go after the right ICA, revascularize it. That's the territory that appears to be hyperperfusing clinically. But did she really throw clots to the basilar and be asymptomatic, and then throw clots to the ICA and take it down? That's not straightforward. On the flip side, maybe she has a chronic ICA occlusion, and she has an acute basilar syndrome, and she was dependent on her right PCOM for her right anterior circulation, and a top of the basilar clot takes that away, and therefore takes away her right anterior circulation, and now she has a right MCA syndrome. So go after the basilar first. I think that's fairly straightforward, and that was my plan A before I met her. And then when I examined her immediately before we started the procedure, she really didn't have top of the basilar signs. She was wide awake. Her eyes were moving just fine, etc. She really just had the left hemiplegia, essentially, and gaze preference and attention, etc. So I kind of talked myself out of going after the basilar first, and it is what it is. So what would have been really helpful would have been an MRI. If you can get a hyperacute MRI in this circumstance, you really could see, is there posterior circulation ischemia or not? There probably will be anterior circulation ischemia if either hypothesis is true, depending on what you're invoking, essentially. But the reality here is that logistically, this is just limited in this case. Our angiography team was already in-house overnight. We had just finished another case when she came in, or when this alert, this basilar stuff all got recognized, etc. So the team was already here. We're ready to go. We have anesthesia ready, and the MRI technologist is not in-house at our center. At least they weren't last year. They are now. They're 45 minutes away. So either we wait 45 minutes for them to arrive and then do the MRI and then go, or we just go. So we just went. So in that setting, we targeted the ICA first, again, for the reasons I just explained. This is the lateral view of her ICA. You can see this taper here, and the ICA is certainly out. We get reperfused after 3 passes with a massive clot burden. There's certainly a dissection here. She's open, she's wide open upstairs, etc. And that part is fairly straightforward. The basilar artery is even kind of simpler. It's a simple 1-pass adapt. We took out this mid to distal basilar artery occlusion and reperfused it. We left this left P1 occlusion because the left PCA territory had already been infarcted from a remote stroke. So we just didn't challenge that for that reason. And we were left with this result. So this is her MRI when we're all done. And she had basilar occlusion, which was the acute syndrome, and it was mostly posterior circulation stuff. And then there's this little ditzel of stuff from revascularizing what was probably an occluded right ICA. So I think you're probably never wrong chasing the basilar first, as was our plan A essentially before we met her. I think a hyperacute MRI would have been really helpful in trying to refine where we were going. And the reality is that this is a really complicated story in retrospect. We didn't have any family report. The patient herself has some pretty bad baseline psychiatric disease. There's really very little to go on, and the chronicity of her syndrome suggested that it was, a stuttering phenomena over 2 days, etc. At the end of the day, she had residual left hemiparesis, which, may have always been the case, given that stroke pattern there, and is recovering well and continues to do fine, relatively speaking. So in summary, I think there is a role for advanced imaging in patient selection and certainly strategy for your cases in select and complicated situations. And these are two kind of sides of the same coin where advanced imaging was helpful or would have been quite helpful in these contexts. So with that, I thank you for the opportunity to share these cases with you and invite any questions or suggestions.
Outstanding case. Thanks, Firas. I will leave the mic with Dr. Nasruddin.
Thank you, Dr. Firas, for your nice presentation and interesting case. And now I'd like to welcome and to introduce Dr. Anas Al-Rahimi, who will present the last lecture on the session on medium and distal vessel occlusion. Dr. Anas Al-Rahimi is an assistant professor of neurology at King Saud University, and he is highly respected vascular neurologist and a neurointerventionist. He serves in the neurology unit at the Department of Medicine at King Saud University, also Medical City, and is also part of neurovascular department at the Neuroscience Center, King Faisal Specialist Hospital and Research Center, with extensive training and academic credentials, including an MBBS, PhD, and fellowship from the Royal College of Physicians of Canada. Dr. Rahimi plays a key role in advancing neurovascular care, research, and medical education in Saudi Arabia. So let's welcome Dr. Anas, and the floor now is for him to start his presentation.
Thank you, Dr. Nasruddin, for this kind introduction, and thank you for MENASO and Sven for this amazing joined program. It is my pleasure to join this well-esteemed, respected colleagues among speakers and moderators. I'm going to share my talk right now. Okay, so I'm going to talk about medium and distal vessel occlusion. Well, first, I have nothing to disclose related to this talk. We'll talk about background, natural history, definition, diagnostic modalities, some prospective data about the IV and IA thrombolysis in distal and medium vessel occlusion, and then the recent advancement in the trials with endovascular and mechanical thrombectomy, and then we'll wrap up with the future direction. So at first, as we all know by now, there has been and a major advancement in the endovascular care in large vessel occlusion that started in 2015 and has become the standard of care for patients with large vessel occlusion within 6 hours. And then by 2018, the indication extended to include the 24-hour stroke onset, and that had shown has shown significant benefit in clinical outcomes. And then by 23, the indication has expanded to involve large core infarct as well as basilar artery occlusion. This advancement has sparked and spurred the interest to move it to distal and medium vessel occlusion as the next frontier for endovascular thrombectomy. However, about the recent trials has tempered that enthusiasm about it, which we will talk about in a bit. As we know, the DMVO, it's not as rare as was thought. It accounts for about 25 to 40% of all acute ischemic stroke. And in contrast to LVOs, DMVO has a better prognosis in comparison to the LVO. Like 50% will achieve excellent functional outcomes and 66 to 75% achieve functional independence. But on the flip side, it means that 1 out of 2 they didn't achieve a good outcome or excellent outcome, and then 1/4 to 1/3 did not achieve functional independence, which reflects that the fact DMVO it's not a benign condition. There's a higher recanalization rate of DMVO with IV thrombolysis in comparison to LVO. It was at 50% in the historical data compared to 10 to 22% in the LVOs. There has been increasing number of observational studies and secondary analysis demonstrated the visibility of EVT for DMVO strokes and has shown significant benefit of M2 segment in post-hoc analysis from Hermes collaboration. And that led to, because the increasing data around that topic led to consensus that EVT for DMVOs is safe, technically efficacious, and potentially clinical beneficial. And that was in 2020 where this consensus statement came out in a stroke journal. And then recent trials, the ESCAPE MEVO, followed by DISTAL and DISCOUNT, which was all presented recently to published in New England Journal. DISCOUNT was presented in IC this year, yet to be published. Those recent RCTs failed to demonstrate any significant outcome differences among patients with isolated DMVO treated with EVT plus versus medical treatment, with potential harm as well. But let's take a step back and understand the DMVO a bit better. So we'll start from definition. So there are two ways of defining, or two school of thoughts to defining the DMVO. There's one was proposed by Jeff Saver and colleagues in 2020 in this article, is that they divided or they defined the DMVO based on distance, tortuosity, distal versus proximal vessel occlusion, and based on vessel size, large, medium, and small vessel occlusion. Medium vessels have diameter between 0.75 millimeter and 2 millimeter. The DMVO is considered A2, A3, A4, A5, M2 to M4 of the MCA branches, P2 to P5 in a PCA branches, PICA, ICAN, severe cerebellar artery. M2, P1, and A1 can be either distal large or distal medium based on their caliber. If they are bigger than 2 millimeter, they are considered larger. And then the other school of thought that was proposed by Goyal and colleague, it's focused mostly on the vessel size, and which is considered the medium, where it's between 1 to 3 millimeter, and with limited emphasis on distance, plus added clinical deficit, like equal or more than in IHSS, substantial clinical deficit associated with that occlusion, or less than in 5 with disabling deficit. The DMVO is classified as a primary DMVO de novo. Those one tend to have lower NIHSS presentation, a smaller extent of ischemia with lower clot fragility. And the other classification is the secondary DMVO. Those results from migration or fragmentation of the thrombus from LVO, whether spontaneously, post-thrombolysis, or post-EVT. As you can see in this case, this patient has an M1 occlusion, And then after first pass, which recolonized the MCA, there's an A2 occlusion. So that's a secondary post-EVT. This patient had a proximal severe M2 occlusion. And then you can see in the angiogram, it has migrated even further. Those patients tend to have higher NIHSS, probably because they started as LVO. Then they tend to have large extent of ischemia, similar to the reason that they started as LVO. And they tend to have higher clot fragility because it has fragmented initially. The diagnostic modalities, it starts with the non-contrast CT. So in rich in erythrocyte, thrombi can show hyperdense dot sign in Sylvian triangle vessels in the MCA occlusions and 2 M3 occlusions. But it's not a reliable way to diagnose those. The other way is the single phase CTA. However, there is a tremendous challenge to detect occlusion, especially in the M2 branches. And the reason because they don't run in a horizontal plane when you look at the CTA. This is a retrospective analysis looking at the rate of detection of distal occlusion in the M2 segment, and in this study can be missed in 82% of cases at the time of the initial evaluation using single-phase CTA. It also has a higher false negative rate by using single-phase CTA, up to 13.1%. The other diagnostic modality is the multi-phase CTA, the arterial phase, early venous, and then or peak venous, and then late venous, compared to the single-phase CTA, and you can see the delayed contrast washout in the left perisylvian region that indicate an occlusion in that area. And also there is a new software that will lead to color-coded multi-phase CTA summation map, and that shows that the vessel with maximum enhancement in the arterial phase shows red, and those enhancing in the peak venous and late venous shown in a green and blue. That helps visualization. And also there's the time to peak map derived from multi-phase CTA, and that helps detecting an hypoperfusing area. Compared to the single-phase CTA, the multi-phase CTA has shown almost perfect inter-rater agreement and higher detection accuracy for DMVO. The known modality that we are almost familiar with is the CT perfusion. And specifically, the territorial Tmax delay had a perfect sensitivity up to 100% and a high specificity up to 87.8% for DMVO detection, especially if it's paired with a good technical acquisition. This is a very nice study that came from our colleagues here in King Faisal Specialist Hospital, Fadil Ajlan and his team. Because the reality that the initial detection is done by senior residents and stroke fellows. This was a blinded study looking at the CTA and asking 5 senior residents and 5 stroke fellows to identify whether there is an occlusion in the LVO or distal medium vessel occlusion versus a normal scan. And the detection rates for LVO and DMVO are significantly lower with the CTA alone. It was 82.5% for LVO and 51.5% for DMVO, and which is compared to when CTP is added to the equation, where the detection of LVO increases almost to 90% and the DMVO to 77%. Additionally, adding CTP to CTA significantly improves both accuracy from 52 to 77% and speed, reducing time of diagnosis from 156 seconds to 114 seconds of a diagnosis time. So the role of IV alteplase specifically, this is a combined analysis from observational prospective data, the well-known intersect and prove it. Combined analysis showed that 258 patients with MEVU, median NIHSS was 7, 72% were treated with IV-TBA, and the recanalization or successful recanalization was achieved in less than half of them, 42%. The excellent functional outcome was achieved by 50%. And the functional independence was achieved by 67.7% by using just TPA. The role of IA thrombolysis, this is from a historical trial, the PROACT2 trial. This is a post-hoc analysis looking only for the isolated M2 occlusion. This trial was randomization for M1 M2 occlusion with randomized to the either IA recombinant fluorokinase plus IV heparin or versus IV heparin alone. 44 patients with isolated M2 occlusions were identified, 13 in the treatment arm and 14 in control arm. The successful reperfusion was achieved in 53.6% versus 16.7% with a significance difference, with a favorable clinical outcome was observed in 53.3% versus 28.6% without a significance. There is also an ongoing trial, the RESCUE-TNK, looking specifically for intraarterial thrombosis, specifically for median vessel occlusion in China. So what is the role of EVT in the medium and distal vessel occlusion? This is a hot topic, and these are the trials that have been presented in IC and recently published in the New England Journal, the ESCAPE MEV1 distal, as well as the DISCOUNT, which has been presented in the IC this year. So the three trials, they included in IHSS, the ESCAPE MEV, more than 5 in IHSS, or 3 to 5 with disabling symptoms. The distal equal or more than 4 or disabling symptoms. 41% of the sample size were less than 5 in IHSS. In DISCOUNT, equal or more than 5 or significant aphasia, and 68% were less than 10 in IHSS. The time frame ESCAPE MEV allowed up to 12 hours with evidence of salvageable tissue required either moderate collaterals or core penumbra mismatch or no extensive ischemic changes in CT. In distal, it allowed up to 24 hours, up to 6 hours, no criteria, and then from 6 to 24 hours required hypoperfusion, hypodensity mismatch, with more than 90% of the area is still hypoperfused, not a core. And then in DISCOUNT, it allowed up to 8 hours or up to 24 hours with player mismatch. There is a heterogeneity in how they included the occlusion location. So the ESCAPE included M2, M3, MCA without pre-specifying the dominance, included A2, A3, P2, and P3. In distal, it's specified that only non-dominant or co-dominant M2 or M3, M4, MCA, A1, 2, 3, and P1, 2, 3. In DISCOUNT, it excluded the proximal M2s, but included distal M2, M3, and A1 to A3, P1 to P4, to P3. Device allowed in ESCAPE MEV, it was only Solitaire X as a first-line device. In distal, any commercially available device. DISCOUNT included different devices between stent retrievers and aspiration catheters. The primary outcome for ESCAPE MEV was 90-day MRS score 0 to 1. In distal was a shift analysis of 90-day MRS score. In DISCOUNT, it was 90-day MRS score 0 to 2. So let's dive into the details. So starting with the age, in the ESCAPE MEV distal and DISCOUNT, the age was significantly higher than what was reported in the prior, the pivotal trials, the pivotal LVO trials, as well as the DMVO registries. So in the DMVO trials, all within the 70s, in the Hermes and Aurora, the median age was within the 60s. However, in the subgroup analysis in the ESCAPE MEV and in the distal, there was no trend toward benefit for based on age. The next for the NIHSS, the median NIHSS for ESCAPE MEV was 8, distal 6, DISCOUNT was 8, and this is significantly lower than the median NIHSS shown in the previous observational studies for DMVO, especially in the intervention arm where NIHSS has ranged from 10 to 18. The NIHSS score in ESCAPE MEV in the subgroup analysis or post hoc analysis that showed that the lower NIHSS favor more medical therapy, while in the distal there is a trend toward better with EVT with higher NIHSS, but it didn't achieve significance. The timing is an important factor, as you can see here. Last known well to recanalization in ESCAPE MEV was 358 minutes compared to onset to reperfusion in Hermes, which was 285 minutes. There has been a longer time to puncture and recanalization in the DMVO trials, and which raises the question whether time is specifically more critical in DMVO due to limited collaterals in a specific region. The onset to randomization, when it's less than 260 minutes, was trending toward better outcome with EVT, did not achieve significance. And when it's more than 260, it's clearly showing more benefit with the medical arm, less benefit from EVT. The other part, the rate of thrombolysis, as you can see in ESCAPE, MEVO, distal, and discount, in the intervention arm, specifically, and the medical arm, the thrombolysis rate is higher than what's reported in the historical data. So the outcome observed in the medical arm here in these 3 trials may have been influenced by its higher thrombolysis rates compared to the aerial observation study, where it was significantly lower, ranged between 41% to 47%. Thrombolysis rates in the EVT arm were higher than those in a prior observational study, which may have contributed to what we discuss later, which is a higher incidence of symptomatic ICH. The intervention thrombolysis management did not change outcome in these, whether the patient received or not, in both ESCAPE, MEVO, and distal. In the level of the occlusions, there is higher representation of MCA segment occlusions in the 3 trials. In the ESCAPE, MEVO, higher M3 segments. In the distal, higher M2 segments. And in the discount, higher distal M2 as well as M3 segments. So there is significant heterogeneity and variability in occlusion locations across these trials. M2 occlusion, specifically if it's a proximal and dominant, may have been preferentially treated outside of the trial settings. And so in these situations, findings here may be less applicable to proximally dominant M2 occlusions. And then the sedation parts in the trials, in the ESCAPE, MEVO, they used general anesthesia in 41.3%, and in distal, about 50%. They used generalized anesthesia. So the generalized anesthesia was used higher in ESCAPE, MEVO compared to 9.1% in the original ESCAPE trial, which reflects the differences in logistics around managing these distal and medium vessel occlusions. The other part is the technique used. Stent retrieval only as 100%. In a distal was a combined, where stent retrieval also included with the aspiration. And in discount, the stent retrieval was about 61%. And the higher use of stent retrieval with underrepresentation of direct aspiration alone, highlighting the need for further study on alternative devices and techniques. What about the successful recanalization as defined MTK equal or more than 2B in ESCAPE, MEVO, and distal, and defined as clot removal within 3 passes in discount? It's in the 70s. And this is lower rates compared to large vessel thrombectomy trials and post-hoc analysis, even in Hermes meta-analysis, where the rib perfusion rates exceeding 85%. And it remains unclear whether this discrepancy is due to technical limitations of the devices and techniques used in the trials, or if it reflects clinical decision-making bias around these cases. What about the outcomes? As you can see, there is no difference in MRS 0 to 1 at 90 days in ESCAPE, MEVO, reflecting that the EVT did not show benefit. In the distal, there was no shift in MRS at 90 days. And in discount, in fact, there was higher MRS 0 to 2 at 90 days in the medical arm compared to the EVT arm. The serious adverse event was higher in the EVT arm. The symptomatic intracerebral hemorrhage in ESCAPE, MEVO was higher, 2.45 times higher in the EVT compared to the medical. In the distal, is about 5.9% versus 2.6% in the medical arm. And in discount, almost double, 12%. In the EVT arm versus 6% in the medical arm. And this highlights a point that the MVOs are characterized by significantly small vessel diameters, increased tortuosity, more complex branching anatomy patterns, and greater fragility compared to the proximal LVOs. In those cases, longer procedure times are often required, which may put the patient at risk and complications with time. Most devices used in these trials were originally developed and optimized primarily for LVOs. And that considerations include the size, the stiffness, the stent retriever deployment force and pulling force, as well as aspiration catheter suction force. There is also an operator experience with a steeper learning curve around these cases, as there is an increased technical complexity and requires time to gain and gather experience of performing them. In a skip MEVO trial, there was a higher mortality in the EBT group, and as I mentioned, higher symptomatic ICH. In distal, there was no significant difference in the symptomatic ICH or mortality. In discount, higher symptomatic ICH in the EBT group, but no effect on mortality overall. This is to show that's the difference between the earlier pivotal trials in the Hermes and Aurora, as well as in the escape MEVO and distal. The mortality is higher in the EBT group in the MEVO compared to the Hermes and Aurora. In the escape MEVO and distal are higher in the EBT group, but in the Hermes and Aurora, you can see there is a significant benefit, medical mortality as well. This is an observational study, the DESC study, and this is primarily also for distal median vessel occlusion. It's included 7 comprehensive stroke centers that included M3, M4s, A2 and A3, P1 and P2. In this study, patients were a bit younger, higher in IHSS in EBT arm, higher successful recanalization rates up to 89%, but similar MRS and mortality scores among the groups. So future direction and going from here, so there is an important emphasis on patient selection, and that's something, those are lessons learned from the trials, the 3 trials. So within this heterogeneous population, it is likely that only a specific subgroup significantly benefited from EBT, and others may have had no benefit or even potentially harmed. So that would dilute any overall positive effects. So favorable responders may include younger patients with good baseline functional status. Those can be treated early. And patients with severe symptoms and higher NIHSS score who may have been preferentially treated outside of the trials. I think use of advanced imaging modalities can help, although difficult, because we don't have a standardization of advanced imaging modality in those occlusions. But those are important to identify the target occlusions, to assess the vessel accessibility, as well as the tissue viability in distal territories, and evaluate collateral circulation more accurately. And this is an abstract was presented in the recent European. This came from the distal investigators that showed the EBT plus PMT compared to PMT alone in patients with higher mismatch volume led to better MRS at 90 days, and additionally to a bigger volume of saved brain tissue, speaking about the importance of advancing the imaging modalities in those cases. And this is another abstract, was also presented in the same conference, which showed that the CTA-based collateral status in the escape MEVO subgroup analysis was the only imaging variable associated with the primary outcome in univariable analysis. The other part, other than the patient selection, is the innovation in devices and techniques. There have been multiple recently multiple techniques that have been presented and published, targeting certain techniques to minimize risks in treating DMBOs. This is one of the retrospective analysis of 54 patients treated with the Swan's technique, which is basically a partial release of 70 to 80% of the stent retriever, while the rest remain sheeted within the microcatheter, and then the microcatheter basically pulled as one unit into the aspiration catheter, and then the aspiration is started once it's engaged to avoid any collapse and risk of injury. So what is traditionally used is a full release, which is the outward force against the smaller fragile vessel, and then it will straighten the vessel, and then there is a pulling force that could injure the perforators and the smaller vessels and can lead to bleeding. While the Swan's technique is a partial and sheathing of the stent retriever and then pulling all as a single unit into the aspiration catheter This kind of a technique has shown higher rate of successful recanalization, TK2C to 3 in 92% of patients. There was significant clinical improvement with median NIHSS decrease from 9 to 3 and higher proportion of good functional outcome in 75%, and lower risk of symptomatic ICH occurred in 4%. Minor subarachnoid was seen in 8%. Important to mention, this is a retrospective. This is subject to bias, so it has to be validated in a larger studies. The other studies looking at using of a small aspiration catheters designed for a primary aspiration of DMVO, and that has been promising. These smaller aspiration catheters among different vendors have shown high rate of successful reperfusion with a favorable safety profile in retrospective studies. Again, those are also subject to bias because all are retrospective analysis. These are smaller aspiration catheter, has lower risk of causing injuries to the vessel and designed primarily to handle this kind of fragility. Other techniques that has been also published is the quattro technique, which is using a balloon-guided catheter along with aspiration catheter with the safe advancement of the microwire microcatheter and then deploying the stent retriever. And this has shown a significant higher successful first pass reperfusion with a higher MRS 0 to 2 at 90 days with less risk of symptomatic ICH as well as subarachnoid hemorrhage. The other important thing other than the patient selection and innovation in devices and techniques is the way how we measure outcomes. So the substantial effectiveness of the modern best medical therapy nowadays has likely reduced the marginal benefit of EVT in those patients with distal and medium vessel occlusion. And that's setting a high bar for demonstrating added value by doing EVT. So DMVO may not lead to the same level of global functional disability that we capture typically by MRS in LVOs. So the MRS may not be the most appropriate tool to detect any subtle or territory-specific benefits of EVT in DMVO. And there has been multiple outcome or modality-specific outcome measures that have been proposed to be used in those cases, such as a stroke and aphasia quality of life scale for MCA infarctions, or visual field testing, or the River-Mead behavioral memory test for PCA infarctions, or the 10-meter walk test for ACA strokes. And also, I would like to invite you to read those very nice articles, one published in SVEN and the other one in INR, speaking about these trials as well as the future, digging into future direction and how we move forward. And also, there are ongoing studies and trials. So this is this type of trials. This is examining a specific device, the Tiger Retriever small 13 revascularization device. It excluded patients who received IV thrombolysis, differentiating M2, only involving non-dominant or co-dominant, and included a distinct endpoint of successful reperfusion using CTP or MRP at 24 hours without symptomatic ICH. So it has a unique way of modification compared to the recent trials. And then the other one is a STIP. It's a multifactorial adaptive platform, registry-based trials, using a unique endpoint of utility-weighted MRS and the neurological deficit using NIHSS at 24 hours as a different outcome measure. And then the third one, it's a broad design. It's differentiated M2s, only non-dominant or co-dominant, and should not exceed a 2 millimeter diameter. And the choice of EVT strategy was left at the discretion of the treating neurointerventionalist. So in conclusion, EVT has revolutionized LVO care, but it sounds like DMVO seems to be a different battlefield that should have a different techniques and experience and different way of doing it to tackle them. So the natural history of DMVO stroke is not as benign as previously believed. DMVO stroke is highly heterogeneous in severity, occlusion, location, vessel size, accessibility, tortuosity, and fragility, making a one-size-fits-all approach inappropriate. And then EVT should not be considered the default treatment for DMVO strokes after these trials. but maybe better case-by-case selection for patients that tend to have a better outcome with the EVT. And then thoughtful innovation in devices, techniques, and rescue strategies paired with improved patient selection, as well as outcomes and streamlined workflows has the potential to turn what's today's dead end into tomorrow's breakthrough. And with that, I conclude my talk, and thanks again for the attendees, for my respected speakers and moderators, as well as to the MENASO and Sven for this joint program. Thank you.
Thank you, Dr. Anas, for your nice, comprehensive, and outstanding presentation. So I think now we could open the floor for the question, and we invite our speakers to turn on their cameras and join us for question and answers and discussion session.
So I think, if you allow me, Dr. Ahmed, I think some of the questions were in the Q&A. Some of them are answered. I will go over the ones that are not answered. So,
Yes.
so there's a question from Anonymous. It's I'm not sure what is it directed to the large core versus MEVO. I think probably large core. Do robots have a role in future solution to the problem? Anyone wants to chime in? I think it might be for both of them. I'm not sure if robotic will be a part of our job at some point. I hope not.
Under
But,
investigation.
Go ahead.
Yeah, I mean, robots are interesting. There's a lot of activity in terms of researching them, especially for remote areas. You know, you have, your radiologist, like peripheral radiologist or your cardiologist maybe getting access, and then the robot does more. But I think there's a long way to go before it's ready for prime time. And, sometimes you might just think about what are the liabilities of using a robot. But I'm not sure we're that close to it yet.
I do have a question, maybe to Dr. Nguyen Tan. So interesting case you presented where you pulled a clot and you did not expect the patient to have anti-gravity next day. That brought up the idea to my mind is, should we really go by aspect, by pure number? Like the same thing for NIH. Like when my residence fellows call me, NIH is 2. I was like, 2 for what? Because 2 for aphasia is different than 2 for numbness, right? So should we probably look at aspect in a different way? Like, for example, M5, M4, M6, and the dominant, non-dominant versus caudate, yes, no, and then we go from there instead of taking it as a number.
Yeah, it's a great point. So there are lots of people who look at cortically weighted aspects. I forgot to mention Jim Siegler did some work on that. Might be more relevant than the deep structure aspects. So, when you're triaging these patients, everything is so rushed. You say, okay, young patient, biggish core, I'm just going to go. And then that eloquence, we may not pay so much attention to it because we're just, like treat first and prognosticate later kind of mindset. So yes, you're absolutely right. It's good to look at all the nuances, but it does take time to look at that. And then, will it really change how you act, right? Because altogether, these large core trials didn't score by eloquence, they just scored by numbers. And so that's basically the data that we have to ride on. But yeah, absolutely. NIH stroke scale, a lot of criticism as well. And, Dr. Al-Rohimi gave a really nice talk on MEVOs. And obviously that does play a role in terms of how do you determine who's eligible or not. So it's still very important because it's the most reliable inter-rater scale we have at this point. But I still, believe in it, and I still trust on it a lot in terms of making decisions.
And I have another question for Dr. Tan. Do you think that AI-assisted non-contrast CT can become a reliable substitute for advanced imaging in the near future?
Sorry, AI-assisted?
Non-contrast CT.
Oh, yeah, that's a good question. My thinking is that we should train up, meaning, you are all physicians with, very knowledgeable in neurology, and you've looked at CAT scans throughout your training, and that if you're comfortable, having read a bunch of CAT scans and making the correlations with your patients and their outcomes, that should be good enough to make a decision. But of course, the hiccup lies in patients who are in primary stroke centers or ERs, where the finesse is not there, right? Because they're not used to looking at CAT scans, and these are the primary ERs who have no idea, and so they rely on something else. So in those situations, I think that AI-driven interpretation of CAT scan can be valuable because it will hasten the pickup in terms of I need to call, Dr. Ahmed for, triage for thrombolysis or thrombectomy. So in those cases, I think it's very valuable. But in a well-run, well-oiled, academic center, as many of you are already in, you may not need it at all because you're more than capable of making that decision on your own.
So, any questions from the audience?
I think the other two questions were just questioning the timing, and which I don't think it's relevant, but I don't see any other question. Anything from the speakers?
I saw something about cerebral autoregulation and blood pressure management. I don't have a great answer in terms of how it affects, like acute ischemic stroke and chronic hypertension, but in terms of blood pressure management during reperfusion therapy, like while you're treating, you're kind of permissive, but then after thrombectomy, there's a lot of blood pressure trials out there, which basically show that being aggressive on lowering the blood pressure to prevent reperfusion hemorrhage may not be good, and especially the Enchanted MT trial, which showed there was actually harm when you lowered aggressively to 120 or less. So that has changed my practice in that if a patient's at 140, 150 after thrombectomy, or even 160, I'm fine leaving it there unless it's like a carotid lesion, then I can leave it there. I wouldn't aggressively go down to 120 because I learned from Enchanted MT it harms patients. So, but if your patient hangs out at 120 after thrombectomy without me doing anything, I'm not going to raise their blood pressure because they auto-regulated there. So we kind of just let the patient do whatever they are comfortable with, or whatever they're doing. They're telling us what they need to be for the most part.
Great point. So since there's no more questions, I would Dr. Nasruddin, do you have any last closing remark before I close the webinar?
Thank you all for being with us today. It has been a truly informative session, and we appreciate your participation and engagement. I'd like to inform everyone that the evaluation for the webinar will be sent to you within the next week. Once you have completed and submitted the form, you will receive your CME certificate. I'd like to thank you all for your time and for your attendance and for being with us. Dr. Ghanem?
Yeah, and from my end, thanks, Dr. Ahmed. It has been really a pleasure. Great collaboration with SVIN and MENA Stroke. It has been really a great collaboration. And before we conclude and finish, I would like to take a moment to invite you all to the two upcoming conferences, the 10th MENA Stroke Congress that's happening in the 17th and 19th to the 19th of September in Cairo, Egypt. And luckily I'll be there representing SVIN as well and meeting the colleagues. And also we'll see you also at the Florida SVIN annual meeting this coming November 19th to 22nd. Please come and connect. We'll bring together leading expert researchers and clinicians across the region and globally as well. It will be a fantastic opportunity to network in these two meetings, exchange knowledge, and engage in insightful discussion as well. Looking forward to see you in Cairo, Masr, Dunya, and also see you in Florida as well. Thank you again for attending, and thanks for the collaboration and making us part of this. Thanks.
Thank you. I'm looking forward to meeting you in person, Dr. Ghanem.
Yes, pleasure is mine.
Thank you. Thank you all for being with us.